and we apologize for the delay, but we were reading the response that all of you so diligently gave us at the beginning of this morning. I think that's helpful to us so that we can your thinking too and keep understood ours. So we'll proceed with calling the roll, please.
I'll start with you, Commissioner Chow.
Present.
And President Green.
Present.
Thank you. I'll read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Romantic Ohlone, who were the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land, and in accordance with their traditions, the Romantic Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working in their traditional home. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Romantic Ohlone community by affirming their sovereign rights as First Peoples. We can move on to item 2, the approval of the April 27th meeting.
So the minutes are for approval of the reading corrections to the minutes, and if not, a motion to accept.
Move to approve.
I will second that.
Is there any public comment on the minutes in the room? Yes. So if so, please come to the podium. There, everything's in the packets. So if you have comments, please step to the podium. No? Okay. All right, no public comment. All those in favor?
Aye.
All right, thank you so much. We can move on to item 3, the regulatory affairs report.
Good afternoon, Commissioners. Emma Moore, Director of Regulatory Affairs. I know it's been a couple of months since you've seen me due to holidays and survey activities, so I apologize for my absence. And so we've got I'm just going to call it a whopper of a report this month because we've combined all 3 into one. So I think first to highlight on the pending surveys, the big one is that our Joint Commission lab survey is tomorrow. So it is coming outside the window. They were supposed to have been here by last week, but they say jump, we say how high. And so they'll be here tomorrow, Wednesday, and Thursday. There will be 2 surveyors looking at the lab. Additionally, our level 1 trauma re-verification with the American College of Surgeons will be July 16th and 17th. So that has been scheduled. We are looking forward to that. And then we do not have any updates at this point on those top 2 lines of the outpatient dialysis recertification nor the GAC licensing survey. So we continue to wait in anticipation. Moving down to the survey activity. Again, a long list. I will do my best to summarize it. So you can see there both on March 16th as well as April 29th, we had Department of Public Health kitchen visits, the first being for a complaint and the second being the twice a year environmental health inspections. No significant issues found with either of those. We passed our inspections. On March 20th, the Department of Healthcare Services came out to the Merck, look at the Behavioral Health Center, and did their annual relicensing. We were all surprised, including the surveyors, because it had only been 9 months since their prior visit. We were expecting them right about now, but we'll take it. We have not yet gotten that plan of correction. It typically takes 6 to 9 months to receive those, but we only anticipate refinding. So kudos to the leadership in that area. And then you can see on April 15th, and then again on the 27th, CDPH came out for an extended visit to clear the 2020 many of the 2024 and 2025 facility reported events. And I do want to note, because you'll see it later in the report, that the one on April 27th is labeled as a complaint validation survey. It was entirely facility reported events, but for some reason, unbeknownst to me, they decided to go through the CMS complaint validation process and formally called it a survey. But overall, the results of that, while an unexpected and intense process, I'm happy to report that we don't anticipate any major findings from those. So from the first visit on April 15th, there was only one facility reported event for which we got a deficiency. We have received that plan of correction. It'll show up on next month's report, but it had to do with a retained foreign object, specifically, it was a glove tip, but specifically that wasn't sent to pathology. So it was visually identified and documented, but not by the pathology team. And so I'm happy to report when we got that plan of correction, it was considered optional. They said we had deviated, but we were in compliance with the conditions of participation. Because we've done all the work, we elected to go ahead and submit a response. But overall, that will be closing that out. And then secondly, the complaint validation, you can see there on April 27th with the 19 sexual assault. There were 2 that there potentially will be findings, I think just related to the course of them, but overall, they were able to close those without any issue, and we're still waiting for those reports. So I will give you greater details once we receive them. The last 2 on there, May 28th, the Board of Registered Nursing came out. They're doing some ongoing investigations into various cases. And lastly, Cal OSHA came out on May 29th, which brings me to Commissioner Chow, your question about kind of the December event and where we stand with that. So you can see there under plans of correction submitted, we did back in April, March, I've lost track of time, submit our joint commission response. So we are currently in the monitoring phase. Just once we get that data cleared by Joint Commission related to the December event, it will be closed from a Joint Commission perspective. Your question was specifically about CDPH, and I am happy to report that there were no deficiencies associated with their visit. So they did not issue us any deficiencies with the December 4th event. So that is also closed out. It's reflected on just the graph is a negative 2567, which confusingly means that there were no findings. And so the last piece there that is very much an ongoing manner is Cal OSHA. So again, from a workplace safety standpoint, and so that is very much in process, and the city attorneys are heavily involved in that at this point. Moving to the second page or section 4 of our report, the facility reported events. Again, our year-to-date total is at 28 in comparison to 71 for all of last year. So I know the first couple months, January, February, we reported quite a number of events, but we seem to be leveling out, knock on wood. And so in March, we had 2 hospital-acquired pressure injuries, 1 abuse allegation, 1 unsubstantiated sexual assault allegation, and then 1 rhinovirus outbreak that were reported. And I do just want to highlight that abuse allegation was an outside caller making a threat to a 4A patient, not that there was any substantiated abuse that occurred. Then in April, 1 unsubstantiated sexual assault allegation and 2 other cases, measles, as well as coronavirus non-SARS. And then in May, 1 unsubstantiated sexual assault allegation, and then a strike notice, which happily did not end up coming to fruition due to their agreement, and then another measles case. Moving to page 5, you can see that we are continuing to monitor for the 4A Fire Life Safety Survey, as well as the Joint Commission Ward 86 survey, and lastly, that complaint validation, so related to discharge planning. So we will continue to report those. They will go through the PIPS process, and you will get the data. And then moving to the pages 4, 5, page 4 is the complaint data, and you can see that complaint validation survey that was initiated in April. And again, as I mentioned, that was not an actual complaint, simply the aggregation of those facility reported events. That's how CDPH elected to pursue that. And pages 5, 6, and 7, because we had so much activity because of those surveys, the changes are summarized on the very last page of the report. So again, it's primarily hospital-acquired pressure injuries, retained foreign objects, and sexual assaults. Those were kind of the 3 buckets that CDPH came out to close out for 2024, 2025. So the good news with that is, again, we are continuing to monitor as they give us direct feedback. We're happy to not have quite as many on our ongoing radar. I will say the fact that they are clearing the docket does suggest that general acute care hospital survey may be happening sooner than later. So we are continuing to prepare for that. And with that, I will stop for questions.
Commissioner, let me check for, is there any public comment on this item? So you've got 3 minutes, I'll set the timer on,
Okay. Is there a microphone?
The mic is set again.
Okay, so can we start now?
Yes.
Okay, so, in regards, my name is Jessica Pesico. I'm a nurse, and you already know my background. So, from what I hear, based on what she's saying, there's a number of, allegations involving sexual assault, issues with pressure ulcers, and a number of other issues. We know that if we do could we re-examine how, SFGH, not only prevents these issues, but not only monitors these issues, but also treats these issues. I know that there has been some problem in the past with some of the education regarding some of these issues, not only just for the actual healthcare workers, but non-clinical staff as well. So if we can try to look and see how we can fix these issues, because we know that these are costly for the department, not only to treat, but it also affects their insurance money, right? Especially if these issues are reoccurring over again. The other issue is that there's not enough quality control or regulatory that are trained as a nurse. So that really affects how we manage and prevent these problems. If we could please hire more staff to address these issues, that would be best. I know that they're trying their hardest, and I know with the Medicaid budget cuts, this could be an issue, but if we could figure out some funding for these positions, that would be great, as well as some funding for training, because we know that if we prevent adverse events, then we're going to have better cost savings in the long run.
Thank you. That is,
And we thank you for your testimony. It's very helpful. And those are actually all the topics that our committee does. So thank you again for reminding us that the public is also interested. Okay, question.
Yes, I was curious to know, wonderful report, thank you, you're always so clear, it's much appreciated. What types of issues would the Board of Registered Nursing be looking into? I don't recall seeing them listed on these reports in the past.
So there has not been significant BRN activity in recent. They seem to have recently taken up our cause, and so we've been in contact with several of their investigators. So it can come from a variety of sources. So in some instances, it can be something where there's a concern for diversion or a concern that some other law has been broken, and so the organization makes the decision to report. In other instances, it may be a complaint, either from a patient or a coworker that they're seeing something that they're concerned about. And so typically it's the Department of Consumer Affairs that comes out, they send out an investigator to investigate on behalf of the Board of Registered Nursing. Their investigations do tend to run several years in length, and they do not officially apprise us of the determination because they're not investigating us, they're investigating an individual, not any different than the medical board. And so we are party to, we have records, they subpoena them, they're able to do their investigation to decide if the board would like to pursue any limitations.
So would this be something that would be a facilitating reported issue or an anonymous complaint? How does it even get to them?
So it can get to them from they have a website where you're able to fill out an online form, or you can send them a letter. I think, or they may even accept emails these days. So it really depends on, not any different than CDPH, where everyone technically has the right to submit a report. But I think in many of the instances, it is coming that there has been an identified quality of care issue or some other regulatory infraction such that their license to be called into question.
Thank you.
Well, thank you for this very extensive report and a great deal of activity occurring over the past 2 months here. Do we have any hospitals that actually are going through their tried annual survey and that are in the immediate area so that we actually have an idea?
I think I've heard of one maybe in the last 6 months, but otherwise it doesn't seem that there's been a significant uptick. It is my general understanding that everyone is well overdue at this point, that they, mostly stopped doing them during COVID, and I think on a case by case basis, they're starting to pick them up, but we have not gotten a sense of a dramatic uptick.
So within all of these activities, where would we find, or under what category is that report that the company should do this?
So it would be under the 2020, let's see, we would have reported it in 2025. So it would show up on page 6, just as us tracking that it was closed without deficiencies. So likely in December, you can see there that there were 5 self-reported events. And so one of those 5 is representative of the 486 event.
But how is it that we didn't have it issued in Darvis penalty for the event?
So I think we at this point are dealing with 3 different agencies. So Joint Commission issued us condition level findings. They came out initially in December and then came back out in, my time is escaping me, late February. And we were able to clear those condition level deficiencies. CDPH investigated and did not issue us any deficiencies at all. So there was no issues. And the final one is Cal OSHA. So from a workplace safety standpoint, so that is where the penalties are coming from.
Okay, so it's within Cal OSHA.
Yes.
Oh, well, that's helpful to us because otherwise it kind of reads that we were thinking of a more clinical approach. But let's see, it's the Cal OSHA issue of security.
Yes. And again, I think not that everyone isn't taking it seriously, but I think looking at the event, it was an employee related, so it makes sense that Cal OSHA that CDPH and Joint Commission, while looking at it holistically, are typically taking it from a patient safety standpoint. Cal OSHA is looking at it entirely from a worker safety.
Okay, yeah, and it seemed the Cal OSHA report actually validated the department's own reviews and the outside reviews and the corrective actions that are being taken. So I would imagine in the future we will see then those corrective actions.
Yes, I will say that
In
it is,
terms of tracking them.
yes, it is under appeal, and the city attorneys are heavily involved. So we are collaborating with them, but I could see it taking a much longer duration of time for it to be worked out such that does appear. But I'm happy to give you any updates you'd like to see.
Good, if you can give us an update.
Sure.
Each month as to where that one is, that would be helpful to us as we facing the public.
Absolutely.
About this, and that's a very good explanation in terms of trying to work out the issue of patient and quality care versus very important issue
Yes.
of security strategies, which I think the department, certainly not just for in general, but department-wide are really taking a very responsible approach. So we want to make sure that stays on track.
Happy to.
Thank you. Any further questions?
Thank you.
And thank you very much and welcome back.
We can move on to the hiring vacancy report.
Hi, good afternoon, Commissioners. I'm Jennifer Magnuson, Hiring and Selection Manager. The ZSFG vacancy rate for May 2026 was 6.22%, 1.13% with attrition savings. There were 6 hires between May 1st to May 31st. These included 1 2736 porter, 1 2742 radiologic and technologist lead, 1 2585 health worker 1 2908 senior hospital eligibility worker, and 2 2320 registered nurses. The May RN vacancy rate is 3.21%, negative 1.61% with attrition savings. And there were 6 separations during this time, which included 4 retirements.
Is there any public comment on this item? Yes. No, you're the only person who's not staff. Please begin.
So, from what I see from hiring of specifically nurses and a few other positions, is that this report contains a lot of full-time employees. but, based on experience and interview, there's more people who are getting hired for these temporary or per diem roles. And the problem is that when you have these temp or per diem roles, either the problem is that when somebody doesn't meet that mark, they're not performing well for these temporary roles. What happens is they either quit, they get fired, or laid off, or whatever. And then when they have to rehire for this role, because either they see that there's a need for to fit or fill this role, or the position is a requirement. Then we have to retrain these temporary employees, which takes up more money because, as we know, if there's higher turnover, that leads to more money spent. So if we could shift some of these positions, instead of hiring more per diem and more temporary employees, if we could shift them over to full-time employees, we'll get more people who are interested, not only in the position, but who are actually here to stay to work. Because that's what we're trying to get people to do. The other issue is, some of the positions that, we're hiring for, could be consolidated. I don't know how much time I have left, how much?
About a minute.
Okay, so, if we, can fix the page for, our San Francisco career page, and more specifically lay out which department that actually needs more RNs, that would be way more helpful. It would actually speed up the hiring process, and it wouldn't waste our time trying to see what roles are available. Also, moving forward, if next time we could go over some of these roles that are a little bit like eligibility worker, and see if we could have put that into the RN type of role that's there, because we know that insurance is not just a non-clinical work. There are some clinical issues that might be able to go with it. Maybe we could kind of consolidate some of these roles.
Your time is done. Thank you.
Thank you very much.
Finance public.
So I'm very appreciative also of the supplemental documentation you gave us in terms of the use of registry and CNAs as part of our review of the budgets. We noted, or as I noted, in our notes to you all, that there would be a usefulness that the commission believes would be important in terms of the Glenn Thomas Committee taking up some of the progress being able to be able to reduce costs, especially general in terms of the use of different personnel to stay within the expenditure budget. And we all recognize this is quite difficult sometimes because the flux of the patient population, but for us then to be able to help monitor and review would be of benefit also to the commission to know that there is continued oversight, I guess, every 6 months at the time that they receive the two semi-annual budget reports. So I really appreciate the charts and sort of Commissioner Greenwood finding terrific how helpful they really have. They really are right now in telling us that your use of different categories in terms of the overall almost 2-year span and the decline in the use of registry and part-time workers. So I just want to thank you for giving us that information, and that we continue to follow that in our meetings. That would be very helpful. And then any other information that you actually have in terms of your challenges. I do know, and we will ask, I think I would ask, you share that there's been an increase of use of social workers. I guess either registry or produce which category. But could you help explain, are we with a shortage of social workers and not able to hire them? Or we find that they are really beneficial in moving patients faster and the decks, so to speak, for new patients?
Commissioner Chow and Commissioner Green, thank you. Jillian Otway, Chief Nursing Officer. This report that I shared with you today, we actually share with the SEIU union members monthly when we meet with them to discuss our use of registry. And so in talking to Susan, Dr. Ehrlich, we're going to provide this to you monthly so that you will have the same information. Regarding social workers, I think it's both, Dr. Chow, as you stated. There is a national shortage, and so we are working with the different programs on recruiting social workers, as well as we obviously need them in-house to help us with discharging and moving patients through the system and supporting our patients with some of their social service needs. We currently, I believe, have 3 vacancies, and those are the 3 social worker FTEs that you see that we are using to fill that gap. The remaining registry that you see, a lot of those, for example, the RNs that we currently have in-house are backfilling leave of absence vacancies. And then the PCA registry, we've had a slight increase due to the fact that we have seen a higher, a surge in acuity with our psych patients. And so we have a lot of more acute psychiatry patients that need one-on-one monitoring. And so we're using PCA registry to support that. We also submitted a budget proposal that was approved, and so psychiatry will be able to hire 26.9 FTEs in the next few months to help with that need. And so we should see a decrease once we have those individuals hired and oriented in this registry here. And so because you're going to be getting this report monthly, you will be able to track that as well. And then we've decreased all of our MEA registries. I believe we used those workers in ED for the most part.
Well, it's very nice. I think we have a question, because you also, added the other departments, which I'm sure we would very helpful. Yeah. Yeah, we're trying to find out what PHC is. For registered MEA.
Jillian is on one of the charts, like there's LHS.
Nearly the end, the last chart that you have in terms of personnel.
Let's see, it says
PHC registry MEA data.
PHC.
So we're just asking who PHC is. I mean, which division?
We had, oh, I see. We had submitted registry data for all of the other departments that we review as well. So I'm assuming we have jail health services, and PHC was probably public health clinics, maybe? Patrol, no, it's probably the clinics, because they would use MEAs. I can check to see exactly.
It's primary care.
All of the different areas submit their data to us, and then we put it together in one PowerPoint. Laguna Hondas is here as well.
Yes. No, it's very useful data. Perhaps you can back to us so that,
I will. I'll find out about that and text Dr. Ehrlich so she can tell you. It shouldn't be hard.
any further questions?
Primary care,
Okay.
primary care data.
Thank you very much, and for the additional,
Thank you.
next item.
Yes, we can move on to CO report.
Good afternoon, Commissioners. Susan Ehrlich, Chief Executive for the hospital. I'm here with my usual monthly report. I'd like to focus on the narrative data first, or the narrative report first. It was very hard to pick out the few things to highlight for you because there's so many good things to focus on in this report. Starting with the 10-year anniversary of the building, of Building 25. It's really hard to overstate how important that building has been for providing excellent care to our patients. What really stands out to me about the 10-year anniversary of this building is how important it was during the COVID pandemic to be able to provide life-saving care to patients who presented to us with COVID. We never could have done it in the old building. And you can go floor to floor and patient to patient and see how different the care has been in that building. So we're very grateful to the taxpayers of San Francisco for helping us build that building and to the foundation for supplementing that. In terms of our statewide advocacy, ZSFG hosted a California Association of Public Hospitals press conference on our campus. That was organized by CAPH, hosted by us. We had Dan there, we had Gabe there testifying on behalf of the importance of public hospitals. And I think it was helpful in CAPH's overall strategy because the state budget included an additional $250 million directly targeted to public hospitals to help very partially make up for the loss of funding with HR 1. So that was great to be able to participate in that way. On June 3rd, we hosted our equity awards. There were a number of awards highlighted here. Of course, Jillian Otway received the Career Award for her work in promoting equity, and it was really a lovely event. I also wanted to note number 7, the launch of the EPIC sepsis pathway. I'll talk a little bit more about that when we get to the data, but that has been a labor of love on behalf of the team. It's about 2 years in the making and it's been incredibly successful so far. So I look forward to sharing a little bit more with you about that. Number 12, celebrating Nursing Week. We, as usual, had an amazing celebration overall. Jillian and her team do such a great job with that. I wanted to highlight in particular the 2nd annual Nursing Research Symposium. This is a day-long event that features research done by nurses and teams, and it's really been an incredible way of promoting the scholarly work that our nurses do and the improvement work. So it was really wonderful to participate in that event this year again. A nurse at our emergency department, Andrew Quelvog, won the Citywide EMS Week Hospital Provider Award. I was privileged, along with Dan, to be able to give this award to her for her work in promoting disaster preparedness. And then last but not least, we congratulated Eunice Santiago on her appointment as the Biomedical Engineering Services Manager. This is one of these very small but incredibly mighty teams without whom we could not function. They maintain more than 12,000 pieces of equipment across the campus with just a very few people. And so very grateful to them and want to congratulate Eunice on her appointment. Any questions or comments about that before I move on to the data?
Do you have any public comment?
This public comment on this item once we do it.
Okay.
Well, we can all interact with this.
All right.
I know it may come up in the next report, but your medical staff meeting was incredible. And the work that went into it, Dr. Mercer, you were so terrific and so uplifting and so positive. And really, when you look at the trainees and what they can aspire to when they see the individuals who get the Rappaport and the Credence Awards, all around, it is really incredible bonding experience and really a highlight, I think, of those of us who've been to these. It's really been a highlight of our participation on the mission. So we very grateful and very happy that it went so well. Every presentation was fabulous and the food was amazing. So thanks.
Thanks to our food nutrition department. Yes, that was really great, and it will indeed be on my next report to you. Okay, now I'm gonna go on to the
Well,
third.
no, I was just gonna.
Oh, sorry, go ahead, Dr. Chow.
Add to my absence, and was really sorry sending you to attend, but I knew you were well represented by our representatives who were there. I'm also amazed when you noted that it has been 10 years since the new general was open, because I remember that very well in terms of that afternoon, and so much has happened in 10 years.
So much.
But it's on reflection, it's almost impossible. That was 10 years ago. So thank you again for reminding us, and for all the very important work that's going on, especially in recognition, I think, of all of our staff. And I think continues to show the dedication, and our staff and our physicians and our nurses have the work that we've talked about today. Really, I think, shows that as a team, and I want to commend you again. You've already received a lot of accolades, but to be able to meld together all of this into an effective team really takes a great coach. So thank you
Thank you for that.
for your services.
Yeah, one thing that I always think about in that building, especially when you contrast it to many of the other buildings we have on campus, is that it really honors the teams who work in it and honors the patients we serve. That's one thing about that building, one of the many things that really is special.
I was also wondering, and I thought when you noted that DPH actually organized the visit of our other public health colleagues now. I thought that was very nice. They chose the San Francisco board, and I'm hoping your colleagues recognize how important for us that we're able to be a leader in the discussion of public health and public hospital needs. So,
CAPH knows how special we are. And how special our team is. And so it was really a privilege to host that event there.
that's very nice. Okay, so we'll go on to your second part of the
Data, yes. Okay, so starting with equity, I'm delighted to say that we continue to meet our metrics. And in fact, this past month, 100% of our departments chose an equity driver, which is really outstanding. So we're at 75.4%, which is higher than the baseline. Okay, our next data point is sepsis. So sepsis continues to be off target. Higher is better. Our rolling 12-month average is 33.3%. Our target is 59%, and we are lower than the previous fiscal year baseline. However, we began on the new EPIC build on April 15th. And the team lets us know that as of June 12th, the pathway was activated 261 times. So as of June 12th. And 103, if you go into the medical record, 103 patients since that time had an ICD-10 diagnosis of sepsis. And 90 of 103 patients with sepsis diagnosis also had the pathway activated. So about 88% of the patients who actually had a diagnosis of sepsis also had the pathway activated. So you can see 261 it indicates that there's a great knowledge about and an understanding that we need to activate the pathway, and there's pretty good accuracy as well. So this is early days, but we're expecting good things, and we need at least a quarter of data to be able to show the impact, probably even more. Our next metric is medication for opiate use disorder. And here again, we are red, higher is better. Our rolling 12-month average is 17, our target is 22, and our previous fiscal year baseline is 18. I've thought a lot about this metric, and there has just a tremendous amount of work going into this metric. And what I would say in summary, and we can talk more about this, is that At the time we established the metric for this work, it was early in our understanding of what metric would best represent the work. And I would say today, if we were going to pick a metric to best represent the work, it probably wouldn't be this one, because there were multiple things about it that don't accurately portray the work. So for example, we've had a big push on long-acting injectables in the various parts of the hospital. Well, if you start a person with a long-acting injectable, you cannot give them a prescription to leave with, which is what this metric measures. That's one of the issues. But there are many things you could point to that demonstrate success. So for example, the substance use navigators coming into the emergency department and working with patients, sometimes even escorting them over to the bridge clinic, that has happened quite a bit. And we don't measure that here. So I would predict that when we do our HOSHN, which is coming up in the next few months, we'll probably think differently about this metric as a way of representing success with this work. So I do think we've been very successful in getting eyes on opiate use disorder and getting medications to patients and getting them connected to care, but it's not that well represented by this metric. Okay, physical health length of stay. This one is also red. Our rolling 12-month average is 5.97. Our target is 5. We are well below the previous fiscal year baseline, which was 6.66. So we are definitely moving in the right direction. And you can see there's a whole bunch of countermeasures that we have in place in order to continue to drive this down. So I feel good about the direction it's headed. Percent acute patient days in psychiatry. This is also red. Our rolling 12-month average is 25.3%. Our previous baseline was 22%, and we are trending up. And so there's a number of things that explain what our countermeasures are and reasons off target. I will also say that one of our KPO fellows is actually working on making sure that for the patients we do have, that the documentation is correct. And so we may be able to actually demonstrate that some of the ones that we might have previously shown as non-acute being acute. So there's a lot of different kinds of work going on to help this get even higher. Okay, Merck inpatient bed occupancy. This is another one that's trending up. It's red, higher is better. Our rolling 12-month average is 88.2%. Our target is 95. You can see how much higher we are than the previous fiscal year baseline, 71.7. And the work that Joan and Angelica are doing to do secondary reviews of patients that are denied has really made a difference here. Okay, boarding. This one is trending down, and even though it's red, our rolling 12-month average is 23.5. Again, see how much lower it is than the previous fiscal year baseline of 31.4. We're still quite a ways away from 15. I think that's an aspirational target. It's definitely possible, but there are many things in this sphere where I believe we've been very successful. And I will say that even though we see this 32 number for May, in June so far it's 25. So we had that pop up, but it's coming back down. And the average peak, if you go back to May of 2024, the average peak boarding was, the rolling average was 35. In June of 2024, it's 22, which is almost a 70% decrease. So we're really making a lot of progress here. The incredible work of the team. Okay, total reportable incident rate. This is the industry standard for reporting for safety events. And this one, of course, lower is better. Our rolling 12-month average is actually significantly higher than it was last year. And there's a lot of work going on in this area. I know we've talked about it. And this one is, even though there's no way of knowing for certain, there's a big contribution of additional reporting going on. And the reason we feel pretty confident of that is if you look at the next chart, workplace safety events by harm level, you can see that over time, the low harm level events, the blue in the light blue, has pretty significantly increased over time, meaning that people are more likely to report those lower harm events, which is what we want. And so if you look at, for example, the average level 1 report for the first 4 months represented on this chart is 33. In the last 4 months of the chart, the average is 44. So we've really seen an increase in that type of event. There's a substantial amount of work going on to improve safety for staff and patients on campus. I won't go into that now, but this we think mainly is a reporting issue. Okay, financial stewardship, our accounts receivable days is green, lower is better. And we are not only below our target, but well below the previous fiscal year baseline. The gross collection ratio is off target. Here, higher is better. Our rolling 12-month average is 12.16%. Previous fiscal year baseline was actually higher than that, 12.45, and our target is 13. And we think there's two main reasons for being off target here. One is the increase in observation cases, which we've talked about, is a substantially lower amount of revenue per case. And then we also noticed that our commercial and Medi-Cal managed care plan payments are lower than they were in 2024. And we're doing some work to try to better understand why that is. It's a little bit more understandable for commercial payers. Because they are, always increasing their efforts to pay less money, but we have ongoing inquiries going on with this. And then last but not least, our denied rate. This is an interesting one. You see this big jump. This is, again, we're off target. Our rolling 12-month is 15.52. Previous fiscal year baseline was 15.93, and target is 15.4. This big jump, we think, is actually because our system is incorrectly characterizing sequestration reductions. So as you know, the federal government is able to reduce payments in Medicare when they have a deficit. I'm not exactly sure how they decide that, but they can just take money away from our Medicare payments through this sequestration. And our system is misclassifying those payments as denials. So we think that the number is actually closer to the previous month's amount. So we're, working on fixing that, but that's what we think is the problem. Shall I carry on, or would you like to ask questions about the first section before I go into the second?
Okay, thank you. Let's finish the
Okay.
whole data.
Okay, so the first section is our True North KPIs, and the second section is really about just volumes and status of the house, if you will. You can see that our emergency department continues to be quite busy. So in May, we had an average daily census of 206, which is, really trending upward. On the other hand, even though we're getting busier, our average time on diversion is going down. I feel so proud about this, and I'm so impressed by the work that the team has done in the emergency department. In May, 27.8% on average, and in June it'll be similar, if not lower. This weekend, we were not on diversion at all on Saturday or Sunday. So it's pretty remarkable, especially when you consider where we were a couple of years ago. Psych ED eligibility volume, is generally a bit higher, but nothing really to comment on there. Average length of stay, we talked about in the KPIs, and you can see it here stratified by observation status. You can see, that the observation patients, really by definition, are staying a lot shorter. And so if you just look at the inpatients, the numbers are a bit higher. Lower level of care is also a number that I feel very proud about. It's not as low as we would like to see, but it's come substantially down since the time period you see on this chart. But if you look even further back, it's quite a bit lower even than that. Psych lower level of care is a different matter. We really are stuck there. We've had a little bit of progress, but we've really leveled off, and that's primarily because we have such a difficult time placing patients who need locked care, either LSAC care or state hospitals, and that doesn't seem to be getting a lot better. Transfers to Laguna are pretty stable, about 3 a week. And that is the end of my report. I'm happy to answer any questions.
Is there any public comment on this item? Or on the CEO report? Okay, great. The commissioner, no public comment.
The graphs are absolutely terrific. And, you know, in these explanations, thank you so much, because sometimes it's hard to understand. I was wondering, again, on the financial side, has there been any thought to kind of extract observation and readjust the expectation of collection? And because, you know, this always happens anytime, and I'm sure it happens when, you know, you get paid the lower of your bill charges or, you know, the health plans payment. And if you lower the, you know, you have to go up or else you get underpaid. So how are you thinking about that? It's a brand new effort. And I'm curious to know how you're thinking about it, what that means, what it can really tell us to what extent it's really skewing this data. Or we'll see more in the future because you're putting more people in office.
Yeah, well, I have a couple of things to say about that. One is that we want to make sure that there aren't, first, that we correctly classified every single patient. So our DOCC team especially is really focusing in on the extent to which we are correctly identifying observation patients and making sure that when we can bill for an inpatient stay, we are doing that. So that is work that is ongoing that we want to make sure that we're maximizing. And I think until that work is done, we wouldn't really know how to change this. And that being said, our revenue budget is set for next year. So we're going into the year knowing that we have to look everywhere we can to appropriately maximize revenue. So there's nothing that we can really change about that at this point. And there are many ways that we can maximize revenue, and we will be coming to you every quarter and having a discussion about that as requested.
And then you said something about the not so much the denials as being undercompensated, maybe that we're collecting less. Is that because we're getting collecting less for code or procedure, or is that because the volume is lower? Because I know we've had lower volume in some areas. Wondering whether this is actually per case and how you're investing.
Yeah, what we're looking at is the percent of bill charges that we are being paid. So we're noticing that percentage tick down a bit. And I don't think we know exactly why, but we really want to dig in and make sure that there isn't anything that we could be doing to make sure that, you know, we're getting paid as much as high a percent of our bill charges that we can be. So that also is ongoing work. I don't know if I know the answer exactly to that question.
To what extent does the DPH CFO and then someone like Director Sy get involved, just from the standpoint if he has such vast knowledge of the case information about what goes on? Curious to know whether they're involved, or I mean, how much of this are they helping with?
Very involved. So in fact, there's a big powwow at the DPH level that involves me and Eric Wu and Kelly and Dan and everybody who's involved in MATSR, everybody who's involved in collecting revenue to really dig into this and make sure that we have all the resources we need to maximize the revenue that we have control over bringing in.
Well, thank you. Yeah,
Sure.
obviously, all of us are, what you're hearing are unfolding today. And so we're just very interested in doing anything we can to support learning what you deserve.
Thank you.
So
As
wonderful. I mean, everything's saying what's like your beautiful friends, especially that you are, so many people, so long.
Thank
And we'll
you.
look forward to seeing the census numbers. That's amazing.
We appreciate your support. Thank you.
Not done.
I think Commissioner
I
Conley.
do have a question.
Oh, my goodness. So sorry.
And I would echo everything President Reed has mentioned concerning the report that we got, including the large print. Although in your case, the smaller print was more or less readable. This is even more better, and I might actually even get you to understand all the arrows that are going through there. Really looking forward to how the sepsis reporting is going to come out, right? Because as you said, people are being treated, we're just not capturing it. And I was wondering on the MOUD that we were talking about, it's not possible then to have broken this out into a number that actually were using injectables and that we could then count them as part of, because if the whole objective here was to know who was started on, I mean, essentially it's what it is, right? Who was started on the current pathway, then whichever was taken, oral or injectable, it seems to me should be counted. We were able to do that. Initially, it was only oral, so this isn't really distorting from the past. But if we mark down, let's say the beginning of this year, all of a sudden we now were giving injectables rather than really as a follow-up. That would, I think, not void your previous data, but also allow us to actually have a more realistic number as to how well we are doing in starting people on their road to symptoms recovery.
Yeah, you're absolutely right. And I can't, it's hard to describe how much work goes into defining these metrics and then building them into a system to be reported. So what you're describing can't be changed on a dime. And so what we want to make sure is that what is the best way of capturing the work that we're doing to get people started on the MOUD and to keep them on over time. And basically the summary that I gave you when I presented this initially is that this probably isn't the best metric. It's going to take a lot of work to change it just because, you know, building these things into the reporting systems takes a lot of time. And as does thinking through what the right metric is. You're correct. At this point, it would be better if we could count the people who got a long-acting injectable as well as the people who get a prescription. But we don't have an easy way of reporting that to you right now. But we'll figure it out.
I see the previous data wasted.
Oh, it's not a waste. This is just a work in progress.
I can't do it. But I'd like to see us get through it. While you've been. I was curious that there was a comment that some of that might have been related to that one in which there was participating new staffing or education. Where that was.
Well, it is true in these especially in ED and PES, there's a lot of other things going on for patients other than, and in addition to their, getting them started on MOUD. And depending on the type of visit they have and how quickly everyone's moving and how much education or awareness the provider has about this, it may result in a different path. And part of our work is to get everybody educated and to make sure that we have the resources for them so that we can maximize the likelihood that somebody will get a prescription or get an injection. So I think it's really a recognition of how dynamic the ED and PES are, and that's part of the challenge of getting people started.
So lastly, in regard to the bed occupancy question, it's more a question that I'm trying to understand I would say the breakout of whom we have as inpatients. So not only am I trying to understand that there's a max that we have, and sometimes we've exceeded it, and you can show that by number of days, or in this case, percentages that you presented at the chart. But also, as we talked about, whether ICU days are less or more versus regular days, and therefore then, and is there a drop off in the number of days because we've been more efficient and moving more people through. But and I guess lastly is the question of the intensity of the patient, which of course is related somewhat to coding, but we've got a great coding team. So if we assume that we're looking at the best and we're finding that our levels are dropping, then that sort of helps explain the total decrease in the revenue off of the estimates that you're all making.
Right.
Just trying to track that and see, well, people are getting either less sick, or we are generally much better on regular wards, or they don't need to be in ICU, or we don't have a big COVID block that, of course, then created a larger, more complex patient experience, right? So that's what I'm trying to understand off of our census. Not that I just needed to know that yesterday was 401 and today was 399. But
Right.
What was a mix of that? And is it that we're also then keeping up the level of care? Well, not keeping up, but that the intensity of the patient is remaining the same or is going down.
Yeah, okay, that's very helpful. So our goal is to explain to ourselves and to you and other stakeholders, what is the difference between what we're budgeted to spend and what we actually spend, and what we are budgeted in revenues and what we actually bring in revenues. And our team has been really focusing on that for several months at least now. And I would say we have a really good explanation and both sides of that, maybe 75%. And there are still things that we don't fully understand. But I think the best way of getting at what you're trying to understand about revenues and expenditures is for us to really do the analysis and explain it to you. Because looking at the percentage occupancy in the ICU versus med surg versus L&D, it's not going to give you the full picture because there are multiple things that explain the differences between those things. So I just like to be able for us to come and explain that to you because it really is a complicated picture, both on the expenditure side and the revenue side.
Well, I think that's very reasonable. And I'd say, since this is the report you already have, I could use this as a capacity question.
Yeah.
And then that's exactly, I think, what we want to go to understand this so that it helps us share it the remainder of our commissioners. We are doing everything. They're hearing that every half year. And what I think we were proposing for, especially for general at this point, is let's see if we can do a deeper dive at the committee level and then give assurances to our colleagues that we're understanding what's happening and that it made sense to us as we follow the revenue and the expenditure streams.
Yes.
So we just sort of need to get into that because of the issues that I've raised in our budgetary environment over the coming years.
Yes, indeed. We are well aware and we definitely want to get that to you. And by the way, the chart that I provided for you from our Project Phoenix that shows the percentage occupancy of med surg, we can do that for all the different units. So if you'd like, we can send that to you as well for the ICU, because that sounds like that would be interesting.
I think if you're doing that, I mean, you just sort of put what our capacity is for that
Yes.
particular type of service, then the percentage really can make a lot of sense to us.
Sure.
Maybe for a little while, that will give us a sense as to how this is all going, and we're in need of your explanation.
Thank you. We will provide it.
Okay, thank you very much.
Thanks. Great.
Item 6, perinatal care innovations since ZSFG, and item 4, presentation. Presenters, the bar at the podium is microphone, and so be careful with your pages, and then please let me know when it goes.
Are you good? Oh, yes, you're protected. Thank you.
Another second. There we go.
Great, thank you. My name is Ana Delgado, and I'm the Assistant Director of the Family Birth Center at San Francisco General. And it's my pleasure to be here today with many of my team members who will join, a couple of whom will join to deliver part of this presentation and talk about the innovative care provided by our interdisciplinary perinatal care team. Next slide. So we decided to start our journey through this narrative kind of as our patients started. So in the outpatient setting, in our obstetrics, midwifery, and gynecology clinic, highlighting two of our most model programs, our centering pregnancy programs. Starting with Black centering. The centering pregnancy prenatal care model is an evidence-based model. It's really one of the only evidence-based models known in obstetric care to improve outcomes, particularly in the case of this program for Black families. Our Black centering program was founded in 2021 and has served over 81 families. And here you can see some of our satisfied patients with one of our midwives, Savannah Washington, who's also co-director of the program. As part of the program, patients get access to wellness activities as well. And based on the scientific literature, we know that patients who participate in centering pregnancy have less risk for preterm birth and low birth weight infants, two outcomes that disproportionately impact Black communities. Our numbers are too low to demonstrate those findings in our population at this point, but one could stand to reason that the literature would apply in this case, and we're looking forward to being able to collect more data as we move forward. Next slide. For more than 25 years, we've also provided centering pregnancy in Spanish for our Latinx community. As the first centering program certified west of the Rockies, our Spanish centering pregnancy program has been a model program and training site for clinicians all over the West Coast. We run 12 cohorts a year and serve hundreds of families annually. Centering has consistently demonstrated lower preterm birth outcomes in this patient population, better than San Francisco and California overall, about half as many preterm births in this population. Since 2006, sorry, there's a typo on this slide, it says 2016, but since 2006, our groups have been offered a partnership with the Homeless Prenatal Program, hopefully a community-based organization that is familiar to you. And this partnership has allowed us to provide a safe community space and assistance with navigation and resources at the same time that we're providing prenatal care. Next slide. Here are just some pictures of some of our groups. That's a group that is touring the hospital with one of our co-leads from Homeless Prenatal Program. On the lower left there is a father participating in one of the group activities. And then in the far right is a postpartum reunion, which is one of the highlights of this program, where people come together with their babies and share the next chapter of their journey together. Next slide. And as many of you know, some of the heaviest lifting that happens in our health system is actually outside of the formal encounter, the formal healthcare encounter. It's in this sort of interstitial space that programs occupy, that we see a lot of the magic happen. And Solid Start is definitely one of those programs doing that heavy lifting for us. From helping to launch innovative programs like Team Lily, which you'll hear about in more detail in just a moment, to providing culturally concordant care navigation, Solid Start has been the glue that has held so many of our most vulnerable families together. Next slide. And there's a video there that I encourage you to watch if you have time. It's a really sweet video from one of our Solid Start patients.
As you can see here, we've been steadily increasing both our navigation and mental health services. As someone who has myself been trying to connect patients to mental health services for more than 20 years in the safety net here in San Francisco, I really believe that the success of these programs is very much dependent on the co-location of these clinicians within our and navigators within our clinic space. And we are currently challenged because these positions are philanthropically funded right now, but we do have data to show that they are revenue generating positions. Luckily, Medi-Cal is very generous in reimbursement for these services for pregnant patients. And so it should be possible to convert these positions to more permanent funding. Next slide, please. And I'd turn it over to Nika to talk about Team Lily.
Thanks, Anna. Hi, everybody. My name is Nika Seidman. I'm an OBGYN based at San Francisco General, and I'm one of the co-founders of Team Lily. I had the privilege of getting to present to you a couple of years ago when we just started. Our program focuses on care of pregnant people experiencing homelessness with significant mental illness and with substance use disorders, or really any significant barriers to care that make it hard for someone to access our traditional four-walled prenatal care in a four-walled clinic. We started really out of the family birth centers, recognizing that there was a lot of people, particularly starting in around 2016, 2017, 2018, coming into the birth center who had had no prenatal care and were having really traumatic births, and we wanted to change that. And so Team Lily was birthed really out of that. And at that moment, that was really when, in particular for pregnant people, the opioid epidemic was hitting our patients. The housing crisis was really impacting our patients, and multiple things happening at the same time really led to our patients being unable to access prenatal care. So we started in 2018 with a small team of a pregnancy provider, who was me, a social worker, and a navigator, and we planned to care for around 20 to 30 patients a year. We've grown to, I put those numbers in orange, 2 social workers, 2 navigators, a substance use counselor, 2 psychiatrists, a therapist, 3 family medicine providers, 2 pediatricians. We care for over 100 pregnant people a year and 200 postpartum people and their families a year. And we are really proud and really grateful for what we've been able to do in that time. Just to give you kind of a flavor of our clinic, we're based at the hospital, and we provide what's called a open access clinic, meaning that people can drop in, but instead of seeing someone in the ER who they've never met before, they'll meet a team of people who already know their story, so they don't have to keep retelling it. And in that clinic, they can seek mental health services, pregnancy care, addiction services, as well as wraparound case management. Similar to what Anna mentioned, because of Colleen, we've been able to have our navigators and our social workers bill for their services. And again, similarly to what Anna said, while we have all of our work co-located in this clinical space, the important work really continues throughout the week through home visits, visiting people in the community, in their tents, in their shelters, trying to encouraging them to come into care and seek services. We provide transportation, and as I said, those wraparound services. And the other kind of a really exciting piece since when I last saw you is we now have an advisory board of our current and former clients who have been tremendously impactful in terms of directing which direction our program goes. I'll go to the next slide, please. In terms of what we do and who we care for, as I mentioned, we care for approximately 100 pregnant people and 200 postpartum people and their families a year. Approximately 95% of our patients are experiencing homelessness when they enter our care, and 30% are unsheltered. We are able to help 90% of our patients be sheltered by birth. Again, substance use is very common among our patients. Almost 80% have a substance use disorder, primarily with fentanyl and methamphetamines. And about 80% of our patients enter residential treatment. really right along with that, very frequently, around 40% of our patients have significant mental illness, and almost 80% are able to engage in mental health services through our care. We are very proud that our patients are able to access routine prenatal care through our low barrier services. While our patients have a mean of 4 prenatal visits, some come weekly, and even see our navigators and social workers multiple times throughout the week because we have a lot of work to do in a very short period of time. One of the kind of most important statistics that we're most proud of is the proportion of our birthing people who are able to leave the hospital with their babies, because one of our kind of fundamental principles is to state that regardless of how you come into Team Lily Care, and many people come in while they are unsheltered with an untreated substance use disorder and a lot of untreated mental illness and history of trauma, about 70% of our patients are able to leave the hospital with their babies and parents. Many of that is via residential treatment programs, but historically, what would happen with those families is that CPS would come and break up those families, and the road to reunification was long and very infrequently successful. And so being able to allow people to leave together and continue their treatment with their baby in a supportive and safe environment has been tremendously important to our families. We also are looking at our baby outcomes. 90% of the babies that we care for have up-to-date well-child visits and vaccinations at a year. And finally, what we didn't anticipate doing when we started Team Lily was to think a lot about congenital infections. As you know, the syphilis epidemic has taken off in San Francisco, and we see a ton of syphilis in our Team Lily patients. In just this past year, we've been able to avert 6 congenital syphilis cases. We had no congenital syphilis cases among our patients, which was incredibly important. One of the groups we partner with very closely is with City Clinic, and actually now we do a lot of the disease investigation ourselves that they need, and then collaborate with them closely to provide trauma-informed services so that patients are willing to engage in the important services that they are offering. We are increasingly caring for more patients living with HIV, and we this past year averted 4 perinatal HIV transmissions. And the last thing I'll just mention is that we are now finally treating hepatitis C in pregnancy. And so we've treated about a dozen patients during pregnancy and lactation, which we're incredibly proud of, because for so many of these patients, this is the period in time when they engage in care and they're ready to take medications. And so it's really exciting that we've been able to get our patients those services and cure their hep C and prevent future perinatal transmissions of hep C in future. Next slide, please. Those are kind of the numbers, and I'll just say we're undergoing a much more rigorous evaluation of Team Lily right now. Now that we've been around for a while and we're established, we have funding from the Foundation for Opioid Response Efforts to do an evaluation of all of our patients who've been in our care since 2018, and we're really excited to be able to look forward and see those trajectories and see what happens to those kids who are now in kindergarten and first grade. And as part of that project, we are doing in-depth interviews with patients and hearing about what aspects of our care are most important and what parts of the care they want more of. So to kind of close, I just wanted to share a quote from one of those, which I think is reflective of many of the things we've been hearing. But what the client said was, as kind of opposed to many of the different pieces that we thought they would talk about, like concrete barriers to care, what they said was, it's the judgment. You know, you're already feeling scared, and you don't feel great about yourself for being high. You know, you're dirty and you're hungry. So it's like people judge you. So it's like you just stay in your little circle of hell, I guess you would call it. Team Lily made it easy, to get help. I would really recommend Team Lily. Like, I just wish I had come there sooner, And so what we're really working on now is to make sure that we can try to get our services to everyone in the city who possibly might be interested in them. We've worked really hard on outreach efforts. And I think, again, one of our most proud metrics is the number of our patients who refer their friends who are completely off the grid and not accessing any care to come into our services when they are pregnant and then stay in care for the long term.
So now that we have shared about our outpatient innovations, let's turn towards our inpatient experience. The care team that we have on our labor and delivery, postpartum, and NICU are a group of amazing people. I'm so lucky to work where we all call our work home. And it's a collaborative model of midwives, nurses, and doctors that care for around 1,200 patients a year. And just a fun fact, our midwifery service is celebrating its 50th anniversary this year. It's probably one of the oldest, if not the oldest, midwifery service in the state of California, opened just after midwifery was legalized in 1975. We're also proud of being leaders in human milk feeding and in doula engagement, which is a hot topic that we were kind of pioneers for decades ago. Next slide. I'm going to have Kelly come up and talk about our nurse liaison.
Hello. Yeah. My name is Kelly Brandon. I'm a perinatal clinical nurse specialist at the Birth Center, and I'm also the co-founder and co-director of the Addiction Care Team Nurse Liaison Program at San Francisco General Hospital. And rather than just read the slides, I'll kind of just tell you the story. Our addiction care team has brought so much wonderful care into the hospital, and I think we really nurses felt that impact of having the team in our units. But really, nursing has gotten left behind in the innovations around addiction care. I can name first in nursing school, a lot of nurses leave nursing school with little to no education about substance use disorders and their treatment. And so you've heard a lot about, especially from Team Lily, how we're really opening our doors, welcoming patients. And nurses weren't feeling prepared to care for the patients once they were in the hospital. You can see that a third of patients that walk through the doors of San Francisco General Hospital have a substance use disorder. It's likely our most common diagnosis in our hospital. And so that deficit really stood out to many, many folks. And myself as an educator on the Birth Center, really stood out to me that we really were working hard to get patients in for our doors, and not every team member was feeling comfortable caring for the patients once they were there. You can go to the next slide. In 2024, we launched the program and we trained 6 nurses at the Birth Center to become ACT nurse liaisons. This included really extensive training. We did 14 8-hour didactic courses. We also used independent study courses online, and focused on motivational interviewing as one of our big goals, of training with 5 days of training. And then one of the really innovative pieces of this is we stepped outside of the hospital and we went into our community and learned about the community services that are being offered so we could better represent and link folks. And then another really amazing part of this program is that the nurses got to then be precepted by our addiction care team colleagues. So they went on actual shifts, learned about the work, and in the end, all of the nurses then set for board certification in addiction nursing, and so received certification. We have a 100% pass rate of the certification, which we're proud of. And so on the Birth Center, we started with 6 nurses. We currently have 5 addiction care team nurse liaison nurses on our unit. One moved actually to full-time addiction care work, which I think is a testament to the drive behind that. And then we have moved in 2025, we moved to bringing our model hospital-wide. It was so successful in our own unit that we trained 11 additional nurses to serve throughout the entire hospital. Go to the next slide. This is a short period of time, but we had some time to analyze our data from January to April 2025. And you saw the statistic that 30% of patients who walk through the door of our hospital have substance use disorder diagnoses. And only 30% of those are able to be seen in person by our addiction care team because the number is so overwhelming, and also the need varies from patient to patient. And on our unit, we really hoped that in the Birth Center, we could bring that number to 100% by adding nurses to the team. And we were really proud that in the 4 months that we looked at, we were able to bring it to 100% just in the first 4 months of the ACT-NURSE liaison team functioning on our unit. So this means that every patient who walked through our doors got the education, counseling, and support that they needed. But the bigger impact that is really hard to measure is these 5 nurses working really hard to spread rigorous education to every single nurse working on the floor, and to be right at the elbow when they have questions or concerns or don't know how to move forward with the nursing role portion of treatment for patients. And that's really hard to measure, but we know has made the hugest impact. We have such phenomenal support from the nursing team that we hear constantly that this role is making a huge difference in their day-to-day work and the ability to provide excellent care to every patient that's experiencing a substance use disorder on the first time.
And we'd like to finish our presentation today talking about, I want to go to the next slide, talking about our community accountability board called the People's Collective. They are moving into their 3rd year. This is a group of fierce community advocates that are showing us what it's like to go beyond consultation to actually helping with governance. Our community consultants are paid for their expertise and skills and are advancing our work in every category. As one of the founders of this community accountability board, I can't say enough about the way this group has positively impacted our work, and we're looking forward to their partnership as we work with the Department of Public Health leadership and the Mayor's Office on the Strong Start Initiative, which hopefully you guys have heard about. And I feel if we prioritize community governance, it's possible to positively impact the future of perinatal care for San Francisco families. And one thing I'd like to highlight that just struck me as I was sitting here listening to my colleagues is that one of the things that our community has talked about a lot in these 3 years, which was a big surprise to me as a provider, was how much they are aware of the toll that it takes on us to take care of San Francisco's most vulnerable. Our community is incredibly generous in their empathy for us as care providers. And one of the things that is a thread that comes through all the programs that we talked about today, from Centering Pregnancy with Team Lily to the ACT-NURSE Liaison Program, is how not only do those programs support the patients and their families, but they support us. They support the workforce that comes and shows up day in and day out for these families. And our community sees that, and these are the programs that they also are most proud of. So with that, I just open it up to questions, or I guess public comment first.
Is there public comment on this item? We're on the natal innovations in prenatal care. Okay, no public comment.
Well, thank you for the presentation. Thank you for your service. Thank you for these innovative programs. We refer to Team Lily, I'm recovering obstetrician, but worked at CPMC until January 6th was kind of, and really you have come through for us, and I think made a major impact on the patients that have come through CPMC. I had a few questions, and one would be, what about the portals of entry for Team Lily? In other words, I know, and I'm curious to know, well, think of this, I know that we are struggling to make a dent in our preterm birth rates, especially among our AA patients. And you have 100 certainly that are obviously from all different walks of life and situations with Team Lily. But when do you think you'll get more data? How are you thinking and working? Because I know, there are a lot of CBOs also that are involved, and it would be so wonderful if, regardless of where a pregnant person first enters our system, that they would be funneled toward you. And I'm just wondering how the interactions go with things like organizations like RAMS and some of the others. How are you really coordinating? Because all the elements are clearly here. And the question is, how many folks do you really think you're missing? Talk about outreach. How do you coordinate all these various organizations? Everyone's marching in the same direction. And it's a matter of how you coordinate. I'm curious to know how you're thinking about it, and also how you're thinking about this preterm birth rate, which seems so hard to make a dent.
I really love that question, and you're welcome as a recovering OBGYN to come and work with us anytime. But that kind of portal of entry is something we've been thinking a lot about, because Like you said, you can only count the patients who you see, and you forget about the patients who you saw once or don't realize the patients who didn't show up at all. So I'm going to answer that question in two ways. The first is that when we just started, we did a ton of meetings around the city with basically any organization that would talk to us about who we were. And then over time, we have developed a one phone number system to get a pregnant person into prenatal care through us. It is in partnership with the DPH perinatal stabilization team, which we work very, very closely with. Those are a group of public health nurses who are specially trained and kind of were developed to care for Team Lily patients. And one of the public health nurses holds that phone, and we get phone calls from CPMC, from UCSF, from Kaiser, as well as from the Needle Exchange, from the HOT team, and really any, as I said, CDO that is willing to have our phone number to do a warm handoff in the moment when they are with a client or a patient who is known to be pregnant. One of our main goals is to not disrupt existing relationships that are productive. So for example, if someone goes to RAMS and they are getting good care there, then we will supplement with the prenatal care and maybe the substance use treatment while they continue their mental health services there. I have to be honest that a lot of, especially these CBOs that are used to caring for non-pregnant people, we hear, oh, we're not ready for this during pregnancy. And so what we do a lot of is, particularly through our mental health providers, is coaching those organizations through the pregnancy and saying, hey, you don't have to take this person off their medications. You can continue their care. In fact, please continue their care and don't stop their medications. So we try to do as much kind of coaching around that as we go. And we also find that people really appreciate having all their care in one stop. So for some people, they step back a little bit from those organizations during pregnancy with a plan to kind of re-continue with them at birth. But a lot of that happens, as I said, is through this one phone number that we have kind of plastered around the shelters, around the drop-in centers, and the emergency rooms around the city so that we can kind of reach as many people as we can. Through that work, we've developed something through the Department of Public Health that we kind of initiated that's called a loss to follow-up call, which is my kind of as part of my training is based on in caring for people living with HIV in pregnancy. And there is a weekly loss to follow-up call for people in the city who are living with HIV who are out of care. And I've known about that, and we worked with City Clinic to develop a similar call for pregnant people in the city who are completely out of care. And who initially we focused on those group of people because those were the people who were getting congenital syphilis and syphilis. And so we initially focused that call around the infection piece, looking to see if those people had testing and treatment, and then expanded it over time to really include the people who we're not talking about and seeing in clinic, and to think about how we can, in a trauma-informed way, do outreach to those patients. So in addition to the 100 pregnant people that we care for kind of intensively in clinic, we have another list of patients that are right now it's about 40 people who we talk about each week with members of the Department of Public Health and a couple of different community organizations to try and encourage people gently to come into care and receive services, or for us to bring services to them in whatever way they're able to do it. So those are our best estimates around trying to understand who's not yet in care. And then we also try to keep track of when people come into the birth centers, usually at San Francisco General, sometimes at CPMC, but they call us about those as well to see who we're missing. I have to be honest, a lot of the people who we're missing are people from other counties who moved in like 2 weeks ago. And those are people who we're going to struggle to connect with. And that's kind of why we built out our postpartum care to try and support those families as well. But we are actively thinking about who are those people who are not making it and how we can continue to push ourselves to make sure that we can really reach as many people as possible.
Can you elaborate a little more on your relationship with the CEOs? I mean, there might be a little perv stuff here, and whether there'd be a situation in which you could actually have a member of your team be at one of their sites, because I'm sure getting to the general isn't always an easy thing, especially with people in general.
Yeah, so a lot of it is relationship based, and For many of the CBOs, they're not providing prenatal care, so our offering of something that they want, because people want their patients to get into prenatal care, and what we do is we invite it frequently, which happened last week, for example, someone's case manager from the CBO will accompany them into clinic, and they spend their entire clinic visit together. And so it's kind of trust building with the CBO and the patient at the same time, which we really appreciate because they already have a trusting relationship. Our patients, again, kind of one respondent demonstrated, one of their biggest barriers to care is feeling like we're going to be mistreated and not trusting our hospital and our team. And so having a trusted community member come in with them has been tremendously helpful. And that's how we do kind of most of our relationships with the community organizations. I'd say we get so many referrals from them, and then we refer them back. We're really not trying to replace people's services. We're trying to fill in the pieces that are missing. And because of that, I think / hope it's been quite productive.
And what about the preterm birth rate?
Yeah, so for preterm birth rate, such a good question. We've looked at our preterm birth rate a couple of different times. Our preterm birth rate is no higher than the cities, which I'm incredibly proud of, kind of at an overall level. But our numbers are small, and as you know, you have a couple of preterms birth, and they sway them back and forth. I think the other piece that is incredibly complicated, as you know, as an OBGYN, is we don't really always understand why preterm birth happens. So just as an example, we had a patient who came into our care who was unsheltered and using drugs for the majority of her pregnancy. She had a full-term birth. She went to residential treatment. She reunified with her older children. She got pregnant again. She was so well that she had her pregnancy care with a family medicine provider in the community, and then she had a 26-week preterm birth. And how to explain that? She was asking us, how could this happen? I did everything right this pregnancy. This is so unfair. And she's 100% right. To me, I think there are some big structural pieces that definitely can relieve the stress of our patients, which we know contributes to preterm birth. So there's pretty good data, for example, on housing stability and decreasing the risk of preterm birth. And over periods of time in San Francisco, there have been different opportunities, in particular for pregnant people, to access housing quickly. As an example, during COVID, the Motel 6 was turned into a hotel that was primarily for pregnant people and their families, and we could house people the same day as they came in unsheltered to the hospital. We can't do that anymore. But during that period of time, we were able to know where all of those patients were, do outreach to them, bring prenatal care to them, do phlebotomy there, through street medicine there, really kind of do all of the care that we could, as well as building relationships so people would come into care. Programs like that don't exist anymore. And while I don't think we have the numbers to show it, they are certainly trends that, for example, people being unsheltered over the course of their pregnancy is not going to decrease your preterm birth rate. It is only going to contribute to it. And so I think basic pieces like having low barrier, trauma-informed places specifically for women who are pregnant, and I emphasize that because many of our patients don't feel safe in the congregate shelters. As another example, there was a hotel that was called the Odante Hotel that had individual rooms where, again, we could help people who were pregnant go and stay, and people felt safe there. The Odante was closed. People are now being sent to a navigation center that is downtown by the waterfront. That is, I can't tell you the health workers who worked at the two places, you shouldn't refer pregnant people here because they don't feel safe. There's already so much both conversation among guests saying that this is unsafe, as well as lived experience that it is not safe for women to be there. And so we need low barrier places for pregnant people to be housed immediately so we can bring care to them. I think that is piece number 1 through 5. And then the other pieces are really providing those low barrier mental health services and other services as early as possible. And I often think a lot of it has to be preconception in order for us to really impact this very stubborn preterm birth rate. I could talk about it for hours, but I think those are the 2 pieces I'd say now.
So it'd be interesting to also know, as you analyze the data, how many of them are preeclamptic, how many people are forced preterm, and how many are advised preterm, and also whether there's any information, any lessons learned from Spanish-centered birth, you have some data, and maybe you'll get the same data, but it seemed that that was very successful. So what makes the differences between your VA community and your Spanish-centered community?
And I think one of the beautiful things is we've been able to now do a lot more partnerships as our patients stabilize. They go attend centering and then we co-follow. We do that a lot with Black centering. And so we're hoping we'll get some of the positive effects of centering while also kind of addressing our patients' additional needs.
I was just going to say that centering pregnancy is, to my knowledge, the only prenatal care model that's been shown to reduce preterm birth. So I think the more investments we can make in those programs, the better.
Thank you for all you're doing and for the work. Thank you for the really excellent presentation.
Thank you. I'm soon going to be well, no. As I understand, I'm trying to piece these together. Is it correct that Solid Start and started team building?
We started in partnership with Solid Start. It's a good question. Solid Start is an umbrella organization. And as Solid Start started before us, and in collaboration with their support, we were born. Solid Start tries to find gaps in programming and then support filling it. And in the beginning, we were entirely grant funded. And so, yes, they absolutely supported us with some smaller grants that got us off the ground. And now we're more independent.
And who is Solid Start?
Great question. Do you want me to answer that? Sure. Okay. So Solid Start is a group of, it's no one individual. It is a group of people in the perinatal space who are trying to fill in the gaps. As just you described, there are so many programs that are fantastic and there's a lot of gaps between them. And I think of Solid Start as filling in the glue. So they are, for example, therapists who sit in the perinatal clinic, who provide racially concordant mental health services to patients who don't qualify for Team Lily or don't need psychiatry care and have a lot of trauma and would benefit from therapy and can't get into some of the community resources. They also provide some more limited navigation services to our clinic patients who, again, don't qualify for some of the highest need services, and yet they still have a lot of needs. And those patients might be working with organizations like Homeless Prenatal, who are really overflowing with patient volume and can't take care of all of the clients that they have. So they're trying to plug the gaps in a variety of different ways, and very specifically through mental health services, through navigation, through kind of wraparound supports that, again, try to not replicate any of the pre-existing services that exist in our community.
So is it an organized group?
It is an organized group.
It's a 501c3 or?
No, it's a program within San Francisco General. So it's staffed by, like any of our programs, a combination of DPH and UCSF staff.
Oh, okay.
Yeah.
So it's an initiative from outside.
Correct. Yes. Yes.
Yes.
Yeah.
One final, first, Charlie Burley, you described it so well. I mean, Pete Burley, that we've heard so much about it, but it's really come to life with your presentation. So the last two parts of the presentation then appear to be nursing education for substance addiction, and then a people's collective. Are these two separate type of initiatives under
So the actors.
Solid Start? Or?
No, they're not under Solid Start. Those are independent.
And you're just
topics.
presenting them as being.
We're just giving you an overview of some of the innovations. Yeah, they're not necessarily linked together.
And are those under general?
Correct.
Oh.
Yeah, the Actors Liaison program started on our unit at the Family Birth Center at San Francisco General. And as Kelly said, spread to other floors within the hospital. And the People's Collective is the Community Accountability Board that's funded by the San Francisco General OBGYN division. So our department there pays this group of consultants to work with us on a variety of our programs.
So, going back to Team Lily, and you've been working with grants in part for them. Then, are you then accepting non-Black, non-Hispanic patients, and specifically then the Asian Pacific Islander population, if identified?
We accept everybody
Okay, and then,
who has trouble getting into prenatal care.
right,
If your only exclusion is if you can get into standard prenatal care.
oh, sure. And you had talked about, you know, getting people now into Hep C type programs. So for the Asian community, it's really a need. And we know that federal government has really pulled back in recommendations of the Hep B vaccinations for the newborns. So what are we doing about that?
Offering vaccinating to
vaccinating.
everybody. And our patients, newborns and our patients.
Yeah.
So that would be something in particular in all of our patients.
Correct. That's standard of care for us.
Okay, so that remains.
Yeah.
Okay, because I think Hep B gets forgotten in all of this.
Yes.
And we know that we're talking about it being sort of a elected type of vaccine.
We provide education about Hep B vaccine during the prenatal period so that it's not a surprise to parents when the pediatricians recommend the Hep B vaccine prior to discharge. And I would say, we actually have our medical director of our NICU here, but I would say that most of our patients opt in for the Hep B vaccine. I would say it's rare that a patient declines it.
Yeah, that's really great because some of us have worked actually for like 2 decades on the issue of getting that part of the initiatives that got to be recognized as a universal vaccine. For CPC being treated, because we see that as.
We're not retreating.
Okay, that's a real need, especially for the Pacific Islander community. And so I'm glad to hear that. Thank you. And thanks for the great work and the educational experience that I just had. Let's proceed then on turning time.
Sorry. Item 7 is the staff report, and I'll note that even though it was in the pack, included in the packet, the medical staff bylaws is a separate item, so this is just everything but the medical staff bylaws.
Yes, thank you.
Call for the packet, right?
It's a tone. Yes, thank you. Good afternoon, Commissioners. Mary Mercer, Chief of the Medical Staff. Thank you for having me here today. I'm pleased to present our medical staff report. We have several items in here, and I did send as many answers to questions as I could, but I will also try to refer to them, and I have some updates on the ones that didn't have answers earlier today. So we'll start with the orthopedic surgery service report. And so the reason you have 2 different service reports is we're covering for both May and June, since we didn't have the JCC last month. So we were pleased to review the orthopedic surgery clinical service report, as well as their rules and regulations, some highlights of their work. And I think this was also, you'll see in the some of the PIPS minutes, but it's the orthopedic surgery service is a very broad service. It's very active. I think they referenced a number of serving over 3/4 of the fractures that occur in San Francisco overall. And they do that through 17 weekly clinics, both that are general orthopedics and subspecialties, as well as I think 11 block rooms that are dedicated during the week, active operating room blocks, both for elective procedures and for trauma response. And so some areas of improvement that they focused on, in addition to service availability, or if they're next available, and then also block utilization and increasing or decreasing the wait for arthroplasty. So, and making sure that there's equitable access for our patient population. So they've made a great deal of progress with that, with the OR9, and have some anticipated improvements like OR10 when that can come into play.
And again, they're, lauded for their, both their the pre-medical, medical, and graduate medical experiences in terms of education and leading a lot of both local, national, and global research in orthopedic, particularly in trauma response. In terms of their, so that's the orthopedic report, and I can go over their rules and regulations changes if you would like, and we can take them as one item. Or
Yeah, let's go.
let's try to do that.
Go through this point and look at the changes closer. What do you think? Yeah.
And then there are some, I think there are some questions about I think it was actually in their rules and regulations, which I can cover too. So the main changes were some typographical and formatting items. They also had some changes with regards to updating the American College of Surgeons, and we are in a trauma ACS recertification year too. So all of our surgical subspecialty services are paying close attention to what updates have been made for American College of Surgeons for our trauma center designation. So one of those was the chief of service requirements for orthopedics, requiring a designated American College of Surgeons trauma director and orthopedic fellowship director who meet the criteria for ACS, and so who are trauma orthopedic trained. So our current chief of service meets that criteria, and we updated the job description, future succession planning, so that it's reflected there. That was the main substantive. There was a question about they note in who is on their service, the issue around other observers included in medical students and residents. We have I think I mentioned in the service report, we do have both within UCSF School of Medicine and our existing partnerships through UCSF School of Medicine and UCSF Health's acquiring of the Dignity Health or Common Spirit sites. Some of those had an orthopedic residency program, and then that is now becoming part of the School of Medicine. So it's a separate residency training program for community orthopedics, but it's now kind of covered under the HIPAA and agreements relating to the School of Medicine. So those are some of the visitors. There's also podiatry students and others that might be observers. And I just mentioned that there is an existing policies and protocols for DPH and UCSF School of Medicine regarding any offsite or non usually affiliated observers, what they have to go through compliance and HIPAA training before they observe. And we, as the medical staff, have designations for visiting physicians and visiting medical staff members who might participate in grand rounds. So particularly in orthopedics, with global orthopedics, we have several international physicians that come and learn through observation. So they have those go through the HIPAA training, and then are also only there as observers, not as participants in care. Happy to take any additional questions. Oh, there's also a question about operative notes. And so I mentioned this, we have our HIM team, our Health Information Management team, does help us track and has worked with our informatics team, ethics, et cetera, to track our note closure rates. We've had a big initiative over the last several years to make sure that all of our notes are in compliance with CMS, Joint Commission guidelines, and California regulations. And so for brief op notes have to be completed immediately following the procedure. Operative reports, full operative reports are supposed to be as soon as possible and no more than 24 hours And so we have a system for tracking that, and escalations would eventually go to, within 48 hours, they are beyond that, would come to the chief or staff, and they could have administrative suspension. We have a pretty high compliance rate for that since instituting a number of improvement efforts over the last several years since Dr. Ortiz was chief of staff. And for 24-hour compliance, we're approaching 95%, 48 hours, it's like 98%. And we're constantly monitoring it. Happy to take questions on that.
My own question was, how does the Ortho Institute work as, is it the department actually, and the incorporated segment as the institute?
The Orthopedic Trauma Institute, yes.
And then it sounds like the way they wrote it, that they're kind of a prime center, even for the UCSF training program, not for next.
Yeah, in terms of so the Orthopedic Trauma Institute is a UCSF entity, and it's funded through, there's a lot of philanthropic dollars also that come through there. And so there's a lot of co-branding around the Orthopedic Trauma Institute. I think we noted there's, I don't know how many faculty members, but there are many there's core faculty at ZSFG who are orthopedic trauma, but all of the faculty, or almost all of them, work also at the other UCSF sites. And so there's a lot of cross-pollination of expert technique that both is developed out of trauma experience here and brought to other sites and globally to the Orthopedic Institute, and then also reciprocally that are developed, globally and at those sites. But I'm not sure if the question is around there. To my knowledge, I'll have to ask the dean's office around. There's not. I do not believe there's any DPH funding to the Orthopedic Trauma Institute. It's more that the OTI helps support the Department of Orthopedics within the School of Medicine, and those faculty are part of the group that goes to CSFG.
Well, it certainly is an impressive
Yes.
organization now, or institute and department.
Yes. Yes.
So I didn't have any further questions. I think that answered most of those. Let's continue on the report.
Great.
Thank you.
So the next report is our otolaryngology and head and neck surgery report. And it is a small but mighty service. And again, similar to our other surgical subspecialties, as they note here, the UCSF Department of Otolaryngology Head and Neck Surgery covers multiple campuses, and they have 50 full-time faculty members across all of those sites, and then 8 of those are providing services at ZSFG with basically just a small number of those 8. I think it's 2 or 3 that are full-time, and then the others are like percent time. Or nearly full-time, because actually all of them do rotate through UCSF health sites as well. And then they also they're a very interdisciplinary service at ZSFG with both DBH and UCSF employee clinicians, and audiologists, advanced practice providers, speech and language pathologists, and a number of volunteer medical staff. And notably, they increased their nurse practitioner cohort from 1 to 2, and that has substantially helped their referral process, their clinical consultation follow-up, their referrals into audiology, and their procedures and billing from clinics, which has been really excellent for maintaining services and resources for the group. And they are, I mean, notably, and this comes out in their PIPS report as well, but they are very active monitors of their OR block utilization. The goal is to be above 80%, and I think they're the highest or the second highest in terms of percent block utilization, well into the 90s most months, which is actually meaning that there's really no wiggle room, and they do have a backlog of cases that they try to actively manage to make sure that they're not having delays. So other highlights there, they've had some challenges with their audiology access and kind of they're just increasing demand with our aging population for audiology testing and services. And so they're really trying, they have an equity grant that they received to improve access there and are working through projects to increase access. Okay, that is their item, and let's go to my regulation, or my rules and regulations. There are many changes there. Here we go. I think there was just a issue around some resident evaluation, oral examination, and the order of board certification. There have been some changes at the national level for board certification, and so that was updated in the rules and regs. Happy to take questions.
This is just a tangent. Does Medi-Cal pay for audiology services?
That is a great question. I am not sure. I think there is a component of it that is paid, but I don't know the extent and percentage to which it does.
It's tangential, quite interesting. Now there's all this data that if you don't hear well, that can be the entree to dementia.
Right.
And just curious to know what experience has been with your division in terms of those types of things. It's partly access, but it's partly people creative with the public benefit.
I'm pretty certain that there is a component of payment, but we can get the percentages to you.
Right, and it seemed to me, and there will be, while we'll try that there is a coverage of some sort that we should probably find out even as.
Yeah. I did a quick Google, I'm sure we'll find more information. Their hearing aid caps, it covers hearing aid and audiology services.
Okay, no, it's good because I think there's additional evidence there. I was wondering where, after all, Pride Hall has gone up and yet there seems to be a limit of faculty spaces for people.
Oh, yes, there's a high.
I think I've seen that in other department reports. So.
Yes, there is high demand for space there, and it's very coveted space, and so it's a constant negotiation. And there's actually a UCSF School of Medicine-wide task force that is looking at space utilization, different practices for monitoring who is making the most use of the space, so that we can best match to the services that need active physical space in those settings. And I believe our division chief of critical care medicine is on the UCSF school-wide task force, and so a lot of those practices are going to be implemented at Pride Hall, tested there.
Never seen to have enough space.
Yes.
I wonder, Dr. Only thing said renovation of any of the other buildings could be helpful.
So renovation of buildings generally is on my mind constantly. We have about 70 active capital projects going on around the campus, mostly in Building 5. The next place we'll be renovating on campus is Building 3 because we got some money from the 2024 bond to work on that. I think Pride Hall is a UCSF owned and operated building on the ZSFG campus, and it houses all of the researchers on campus. So I don't think there's any plan or thought at this point that they would expand beyond that building. And just as Dr. Mercer is saying, there's active management in the dean's office in making sure that the space is fully utilized and that it's allocated, fairly and appropriately. So that is just continuing, but we don't expect that researchers will overflow out of that building into our brick buildings.
Okay,
It was a lot to get them out of this brick building.
Yeah.
all right. I know you also need space. Okay, and any questions on the otolaryngology issue? Okay, so let's proceed on to the remainder of your report.
Great. The next is the credentials.
Oh, I might note that they seem very collegial.
Yes, oh yes, they certainly, they really enjoy breaking bread together. We learned that in their service report. Very collegial.
Okay,
Okay, our next was our anesthesia and standardized procedures for NPs and PAs. The main item that was, there were some minor typographical things that were changed, and then the main addition was Protocol 9 for consent and ordering of blood products for transfusion. There are 2 questions relating to this this report, and for the first was about the scope of practice for the definitions that were provided for NP and PA in the standardized procedures. So in this SP submission, as well as in the standardized procedure submission for later on for the community primary care service, they both refer to kind of the same preambles or similar preambles for nurse practitioners and physician assistants. And the language is almost identical. It should be identical. I think President Green had a question around making sure that in our all of our standardized procedures that we're using the same definitions, that it reflects scope of practice. This does reflect what the scope of practice is at the state, but I did want to note that the individual standardized procedures by service might vary. So a NP that has standardized, has been granted standardized procedures for anesthesia, as well as community primary care, might have different SPs that they are allowed to do, and depending on the clinical environment, and that's overseen by the chief of service for that group.
It was mainly the preamble, slightly different.
Slightly different.
Yeah,
There
the
was,
name of uniformity, that's what's on.
yes, and so we will, there was, I think a short, piece in the physician assistant, component that was changed. And I think it also reflects a different workforce, group, that there has been a change in some of our clinics to focus on hiring NPs as opposed to physician assistants. So they might not have paid as much attention to that, but it shouldn't be the same, and I will change it. Okay, and then the next question here was about the transfusion of blood products, and there are hospital-wide policies for those and standardized forms, and it was just that this was granting the NPs in that service the authority to consent patients for blood transfusions. Okay. The next item is our credentialing manual. And there are several updates in this that were mostly related to NCQA updating their requirements. And so there's some technical language that was changed to ensure the verification window, changing it, shortening it from 180 to 20 days from last year, clarifying requests around the credential committee and the committee for interdisciplinary practice, they having a clear review process for updates to privileges and standardized procedures. There has been some updates to our San Francisco health plan, and also motivated some of the changes regarding non-discrimination clauses. And then there were a few areas where non-discrimination clauses were added. And that is the main, and then some, the health plan also had some additional requirements around clarifying our verification methods for licenses and certifications.
Any further questions on those? I think we answered
Okay. The next, yes, the next one is the standardized procedures for the community primary care.
Yeah.
And so this updated a few different items. I mentioned, I think I mentioned the issues around the language for PAs. It addressed the issue for having a collaborative practice agreement in place, I believe, for PAs there. And then there's the prenatal care, and there are a number of, there are a number of items that were added under healthcare management for prenatal care. And then there are some questions from Commissioner Green. So I don't have all of the responses yet, but we have, I messaged both the lead NPs and the service chiefs for CPC, and then also for, to make sure that our midwifery and OBGYN services are aligned. And there were some changes in the prenatal care and other OBGYN related care, where it does reflect, like for removal of contraceptive implant and insertion of intrauterine devices, for example, where there's been, I mentioned it prior, JCCs, there's been a lot of interdisciplinary work across all of our services to really standardize the language and the requirements for initial proctoring, reappointment, et cetera. And so those are reflected here. And the questions that you asked around hepatitis B, screening, as well as all of the other items, we have that work group looking at them. And so there have been a couple of things. I believe hepatitis B antigen screening is mentioned in here. It's listed as HBsAg, but we were wondering if you were referring to Hep C.
Yeah, antibody screening, is that what you recommended?
Yes, so we will clarify. I think that was the item that our midwifery colleagues picked up on that was missing, and so that is, so long story short is we will take all of your feedback, which is extremely helpful. We have brought it to the group. There are a couple of things where things are actually being discussed with infectious disease for recommendation. And then we will make sure that the language in these SPs is reflective of the other SPs that exist for midwifery and the other services, and then we will resubmit those. Yeah, I think there are several that need to just make sure that we're clarifying across. I mean, there might be a couple of areas where it's slightly different from what you have written.
So how should you put those up?
So if you,
Are you asking maybe for them to go reapprove?
I don't think any of them are that critical. I mean, your analysis was dipstick with medical legal questions.
Yes.
It's a pile, you said her to you read that.
yes,
And I think, I don't know the extent to which JCOG recommendations for things like Hep B and the body has been universally adopted. So that's a good question. And then I think NTL presents a fairly standard of care.
yes,
So I'd be a little worried again. I think I always think about it in the environment in which we live and the limitations on acting on fetal abnormalities.
right,
The sooner people know about the better. And there are certain things you can pick up at 12 weeks. And it's a big difference when you find them at 12 or 20. So in that would be one area, especially in the populations where they may have had
yes,
early care. And that was really, those were the main things. And then just having seen many curves from reflex IUDs, I think that's an important warning. A lot of people, you really need to examine someone before, and it sort of says that you need to examine someone before you put an IUD in, because there's an acute reflection.
yes,
You can easily go right through the uterus, not recognizing it. So
Yes.
those are some of the things that I would just point I thought of, but I don't think any of it's critical. I think it's just maybe the next iteration or however you guys want to do it.
Absolutely.
Want to not approve this area just to get some of these details.
Great. So that sounds great. And I think of note, we did involve all the services just to make sure that if we are updating in this one, we will update across. So we will probably do a minor edit across those multiple services and perhaps at a future JCC bring those limited updates to this group, but in the interim, we could potentially propose that you approve these as they are.
Well, I actually would still favor that we investigate the recommendation on hepatitis B. That's what we were just talking about even earlier. And within the city's population, I think to make a real big difference. But it is within the screening test. So if ACOG's recommendation is to put that in, we're following ACOG, then I would suggest that at least have to effective.
Yes.
And the commissioners, Dr. Mercer, based on what you're talking about, does it make sense to, when you send the revisions, to possibly have a summary memo around what was and wasn't? Like,
Sure, we can do that.
what was in alignment with what they asked for, what wasn't, so that you
Yes.
all will know and give a record of what needs to be done in the next iteration?
Yes.
Does that make sense?
That
Before
sounds-
you approve it, you kind of, otherwise you're just trusting that it's gonna be okay.
So we can send a memo this week with the comments of what will be changed in this iteration. And we can have that updated for the health committee, what goes
Not
out.
until July 6th, so we actually have an extra week.
Oh, right, so yeah,
We have
it should be fine.
Day.
Right, so, and then I think if there are things where the group is, like, there's something where there's some additional screening that they actually are discussing adding with ID, that might not be ready for July, so that would be at a later.
And that's why the memo is important, so the commissioners know what was and wasn't changed, and we can all track it for the next iteration. Does that sound okay to y'all?
That sounds fine. Very good.
Thank you.
Okay.
Feedback. Okay.
Okay.
Are you done?
That is, I think that was the last item for the medical staff report.
Right, so is there any public comment on this item? No, okay, great. So commissioners, would you like to make a motion to recommend the full commission approve these?
So moved.
All those in favor?
Aye.
Thank you
Okay.
very much. Dr. Mercer stays for the medical staff bylaws.
Okay, thank you. So I just, again, want to thank the commissioners and this committee, Mr. Morowitz as well, for all of your thoughtful comments and your feedback on the earlier versions of our bylaw draft. With this submission, this is our formal submission to the JCC and to the Health Commission. We are seeking approval to move on to the Health Commission for approval as required by California law. And we included a formal memo, which the city attorney helped us draft, just to kind of outlining our obligations by the regulations, clarifying that the last substantive change was really made in 2019, and for a variety of reasons, there's been a lot of discussion and thought that's gone into these changes in the intervening years. We have incorporated all of your feedback from the review process from April, and then changed those revisions and then submitted the revised version to NEC for review and comment. There were no additional revisions received from NEC. And then following NEC recommendation to advance to the full medical staff, we presented them after a period of review, and there was a vote with a quorum at the medical staff meeting 2 weeks ago on the June 10th. And so the medical staff has approved this version of the bylaws. I think I also mentioned for context that our bylaws committee is very committed to engaging with our city attorney's office and our new council that really specializes on medical staff issues on several issues relating to process and for both medical staff members and for affiliated professionals, and to really examine what are the best practices, particularly across California, and at equivalent organizations, and to make sure that the process for peer review is very clear. And so I just want to be clear that that's really going to be the work for this coming year, and it's going to involve, you know, multiple stakeholders and very expert review by our consulting attorneys. The city attorney's office and our consulting attorneys have reviewed this version of the revisions and are, you know, also feel comfortable with our moving forward with recommending these, but recognizing that we wanted to do a deeper dive. And I think there were some questions that particularly that Commissioner Green raised about process for affiliated professionals and gaps there, that we should clarify process, any differences in process. And then also, I think you asked about the confidentiality, whether there needs to be additional requirements for confidentiality agreements that are formally signed. Having reviewed your comments and questions and the language that's in both Article 3 and then Article 17, there's enough reference, we feel there's enough reference to existing policies and procedures that describe confidentiality, as well as reference to state regulations, and that all of our meetings also are like clearly documented and reiterated that they're protected by 1156 and 1157, that we feel comfortable right with these, still requesting approval for these without adding that change. But we will certainly take your questions to heart and also consider them further with our legal counsel in this next revision period.
And the questions,
Well, I really appreciate the extensive answer. And I'm just, you know, I'm just concerned about legal vulnerabilities, because there's so many little us and does that can change the way things are approached. And the only other thing that I probably, it doesn't follow the medical staff bylaws, but there is that issue of confidentiality of the support staff that are working with you and these confidential conversations and evaluations. So I would just hope that they are also bound in signing.
Yes, all DPH employees have to participate in a compliance and HIPAA training, including our medical staff services team and all support staff there.
Thank you.
okay, yeah, and I also thank Will and everybody else for really taking into consideration our questions and the theories that they in fact have been responded to in the Bible. So, can we take about that?
Yes, please make a motion to, actually, for Dr. Murphy, may I, do
Yes.
So is the July 6th meeting?
The July 6th Full Health Commission.
Where this could be?
Yes.
And does this need to be its own item, or could this be part of the consent calendar like all the policies? I'm just thinking about their motion right now, if it needs to be specific.
That is a great question. I'm not sure. If
We can talk offline.
We can talk offline.
So Commissioner, please consider a motion to recommend the full commission approve these medical items.
So moved.
Second?
All those in favor?
Aye.
Thank you. Roll call.
Okay.
All right, item 9 is other business. Is there any public comment on other business? Okay. Please begin. It'll come back down.
Okay, cool, because I'm kind of short. I'll wait till it comes back down.
No, you need to start talking.
Oh, okay, and then I'll go?
Sound is what makes it, but your time is starting now.
Okay, so my name is Jessica Pesico. You already know my credentials. I just want to thank SFGH for listening to my concern about creating the patient dining room. I appreciate that. I hope this kind of follow through happens with some of what I'm about to report today. So my biggest ask is funding. ZSFG should aggressively pursue targeted support from the Chan Zuckerberg Initiative for patient experience and access gaps. I also urge exploring acceptance of a broader range of insurance plans, including commercial payers, because we know that Medicaid reimburses at a low rate, and expanding insurance options could generate critical revenue for operations and staffing. The other issue is, I'm going to show this on the screen, is that as of July 1st, there's going to be a reduction in the urgent care hours. During the weekdays, it used to be closed at 8 o'clock, and now it's going to be 6 o'clock, and on weekends, it's going to be 4 o'clock. I ask you to protect these hours, making sure that we can stay open until 8 p.m. because as we know, if we have more patients who can't access urgent care, they're more likely to go into the ED. It's going to crowd it. It's already going to increase the wait times. And I have, speaking of wait times, I have made a complaint or a suggestion. I started this on April 13th, and in the report, I asked if we can examine the wait times, not only, at our wound care clinics, but hopefully at our dental surgery clinic and more. Because we know that if we have more wait times, more patients are going to get hurt, especially if there's a delay in care, especially for more acute care problems. The other thing that was an issue was the pests that were in wound care clinic. This has been an ongoing issue. I reported it. And when I talked to staff who are in the wound care clinic and elsewhere, they do not get maintenance right away. Instead, they say we're aware of the problem and there is a do nothing kind of issue. So I had to raise this up and talk to the Office of Patient Experience. When patients are reporting pests, it should be taken care of right away. The other thing is Office of Patient Experience.
Your time is up.
Okay.
However, there's general public comment coming next,
General?
which you could continue, but Commissioner, do you have anything on other business before we move on to your file? So general public comment is now, and it's another item, you can speak about something not on the agenda.
Okay.
Would you like to start? You ready?
Wait, okay, yes.
Meeting continues.
Is that okay, cool?
And so,
Where you are.
Okay.
yeah, and actually, and I'm sorry for this, but would you clap and see if the camera will, clap? Sorry, did you just keep talking?
Okay. Okay, so I'm hoping that this wasn't mentioned today, but on the clinical side of things, the emergency nursing standards require rapid initial triage assessments followed by an ongoing assessments for patients waiting in the waiting room or waiting boarding. And having some of these repeated focus assessments is critical, especially if patients are in the waiting room waiting for more than 4 hours. Usually every about an hour or so, depending on the acuity of the patient, of course. Patients are supposed to be receiving not only vital signs, but a more focused assessment. And this, from what I've seen and from what other patients have been telling me, this has not been done. If signs and symptoms are being missed, especially in acute care setting, you have more likely for complications. And this could also lead to patient complaints. There's also issues with some of the appliances, equipment, and the ED. For example, there is a charging area that I have reported has not been working. I guess staff's telling me that it's been on a commission for over a year, this charging port is so patients can charge up their phones without access to a phone. Patients may not be able to get a hold of an Office of Patient Experience person, any surveyor, or more importantly, sometimes their family or legal representative. But that's a big issue. The other, some of the other issues that I had was the map of the hospital needs to be not only updated, seems like it's from 2017, and these do not account for the ongoing construction, and there's no billing department that's in there. If we could please update this map to include it, that'd be great. Also, if for this meeting, if we could have it so that the panelists pose their questions and then the public pose our questions, that would be amazing because it's hard. I want to take into what you guys are saying as well. And then lastly, if this committee is only on WebEx, and whereas the other full health commission meetings are broadcasted and archived on SF.gov TV, please extend the same transparency to the JCC because it's important that the public be able to see these meetings and hopefully try to improve the quality of care because we appreciate SFG.
Your time. Thank you.
Thank you.
Thank you very much. And aren't we available on it?
SF.gov is only for alcohol commission meetings. All the committees are only on WebEx and all the WebEx videos. Yes, so the public has full access because if they have a computer, if they don't have a computer, then they can watch the videos or attend the meetings in public. But that the SF.gov TV has a cost and the DPH budget a long time ago was just.
But it is available on WebEx
Yes.
and available online. So.
Oh, no, not back and forth. So item 11 is closed session.
Well, before we go to closed session, I would just ask and thank the public for bringing up and let's have a report on if there are changes to the urgent care. I'm sure that may well show up on our plots, but I think maybe it's just great to just let us know what is happening here and what the experiences.
Yeah.
Okay, thank you. Let's proceed.
Sure. Item 11 is a closed session, and is there any public comment on whether the committee should go into closed session? It's specifically about the closed session, nothing else. Pretty narrow. Okay. So commissioners, no public comment. Please consider a motion to go into closed session.
Move to go to closed session.
Okay.
All those in favor?
Aye.
Right. So anyone who's not required for the closed session, please leave the room. I'm gonna do the same thing electronically. It's a minute or two. Okay, we are back in open session. Commissioners in closed session, you approved their financial report and 2 months of PIPS minutes. Please consider a motion to disclose or not disclose discussions following closed session.
Move not to discuss.
I would second that.
All those in favor?
Aye.
And please consider a motion for adjournment.
Move to adjourn.
Second.
Oh, all those in favor?
Aye.
Thank you.